Hello, everyone. My name is Dr. Rebecca Seagraves, and I am the CEO of Pelvic Health Network. And I could not be more thrilled to have with us Princess Castleberry. Princess, you are the CEO of Castleberry Global. You're a featured TEDx Detroit and global speaker with wellness and risk management expertise. And Princess's focus has been helping organizations protect their people, purpose, and profits with learning experiences that make wellness and risk actionable. Princess, thank you so much for joining me
Thank
today.
you. Thank you for having me, Rebecca.
Yeah, so we met at the Black in Business um, Goldman Sachs program. I'm so happy that we were able to actually have that opportunity to meet and to be working in such a wonderful program. And I was speaking about our business's mission to really expand access to physical therapy and occupational therapy in the hospital after birth. We were talking a lot about
Yeah.
the risks associated with that, and you were sharing a little bit about your experience. Can you help kind of the audience understand what does that mean in terms of making wellness and risk actionable?
Yeah. So my particular brand of wellness and risk management is somewhat niche, right? Because when you hear those terms, wellness, you think about the wheel immediately. So it's such a broad concept. Risk management, such a broad topic. But really, Rebecca, I focused on three areas. I focus on helping organizations make better decisions and avoid decision fatigue, managing stress naturally, and resolving and reconciling conflict. So when I talk about risk management and risk, just to take a step back, a risk is just the possibility of harm or loss to something of value. But I also think that risk is undergirded by this immense opportunity, right? Opportunities to just get things right and to capitalize on prospects and things that help us grow and learn and develop. So I absolutely love this world, and there is so much risk and opportunity when we're talking about health and maternal health in particular.
I absolutely agree. I even shared a story with you where we were grappling physical and occupational therapy is really unheard of in this space when introduced so early as the hospital stay. And when I speak a lot to kind of our colleagues about the services that we would provide someone after a normal surgery, like when I say normal, I'm not including the most commonly performed surgery in the world, which is cesarean section. I'm thinking about the surgeries they would normally be consulted on, someone after a gallbladder surgery, someone after an intestinal surgery. The amount of risk that we've seen over the last few years and just practicing on the maternity unit, we're seeing hospital units that are not giving kind of enough time for moms to recover and sending them home way too early. And so when introducing our services that would otherwise mitigate that risk, we really have to be aware of the culture involved. And that's where your expertise to me comes in so importantly when taking these next few steps, because there is so much risk already that hospitals are grappling with, but then also that's placing mothers at unnecessary risk as well. What would be kind of your expertise that you can share in this area?
Yeah, I think that just staying on brand with things being very practical for me. One of the biggest challenges, and when you and I first talked, I think we connected so much because I immediately went into TMI mode and started sharing a bit about my birthing story, my first birthing story. But that story, which I'm sure we'll cover in a little bit, made me think of the most practical solution is just active listening. And I know for some people that sounds cliche, but as someone who is involved in or has been involved in many, many types of loss scenarios, many different types of crises across the health industry, construction, the insurance brokerage world, the staffing world, which is very vast. I've seen lots of losses, and active listening is always key, and it can be key before there's a loss, right? And so when I think about maternal health, there's a lot more listening that needs to take place on both sides. Listening among medical professionals for continuity of care, and then a lot more listening to the patient. what the patient is experiencing, not being so prescriptive, but actually taking time to really understand and think holistically about the fact that, this woman in our birthing case, just gave birth, sometimes in some cases for the first time, but in every instance, every single birth is unique. I don't care if a woman's giving birth for the first time or the fifth time. Every single birth is unique. And just understanding what that woman is experiencing in that present moment, hearing them, and then prescribing care is really important.
That's really rare. You're almost switching the tell with the ask. It's ask, don't tell.
Yeah.
Ask, don't tell. And that would involve that active listening that you're describing. You did share your birth experience with me, and I would love for you to maybe just expound on that. How has that shaped your conversations with organizations and managing risk?
Yeah, so much about my experience as a first-time mother, which that was 13 years ago, I became a mother. And so much of that experience was around communication, right? I wanted to communicate with my doctor about everything because it was my first everything, my first flutter, my first kicks, the first time I'd heard a heartbeat coming from inside of my body that wasn't my own. So there was so much excitement about it. And then obviously a bit of trepidation. So I had communicated with my doctor a lot about my wishes, right? I wanted to have natural birth. I didn't want to have certain drugs or certain experiences. I went through the birthing classes and I shared everything. So the relationship in my mind, even though it was very professional, it was such an intimate relationship from the perspective of a mother. And so when I think about what I talk to organizations about today, I advise them to not neglect the inherent intimacy in medical relationships. Don't ignore that natural closeness for the sake of professionalism, right? I know there's professional codes, but there is a way to have a bit of both. And that sort of intimate relationship entails a lot of communication and a lot of listening. New mothers ask a ton of questions. I know I did. And I was sharing all of this information about my fears, about concerns, my desires with my doctor. And that experience went really left for me. The first way it went left for me is when all the way back from when we were talking about the date of conception. My doctor and I had about a 2-week difference in when she calculated based on measurements, based on dates, that I had conceived my child. And I told her that based on what I thought was the conception, that my child should be due around February 14th of the year he was born. She had given me a due date of March 1st, which was 2 weeks off. I disagreed, but went along with it. And as the pregnancy progressed, I was having a whole host of issues. I'm a woman that has fibroids. I was not consuming enough water. So we had to do some corrective things with my water consumption and diet along the pregnancy. But as things progressed toward the end, the biggest misstep was that my doctor had a planned vacation that she did not tell me about. And somebody might say, well, that's that doctor's business, but this is my first birth, and she was my partner in it from my perspective. And so she did not let me know she was going on a planned, scheduled vacation. And it was at my due date. I had carried my child all the way to the due date. And she had advised me, if you don't go into labor before your due date, go into the hospital on that date. So I was eagerly awaiting, March 1st was coming. So I followed the orders only to be found or told that she wasn't going to be there. So instant disappointment. And then that was followed by an onslaught of challenges that I faced because my body never naturally went into active labor. My labor had to be induced. I had to endure a number of procedures to help the labor progress. And I'm giving you the long story short version because hours, but it resulted in me having a C-section. And that C-section was followed by a host of challenges that my child faced, because what I had been sharing with my doctor as this very intense rumbling during my pregnancy, it was sort of dismissed as flutters and the baby kicking or moving. And in fact, my son was having an in utero stroke. And I had a child
Wow.
that had parietal lobe ischemia.
Mhm.
And so I learned lots of medical terms right away. And I will, just for audience sake, long story short, he is a vibrant, healthy, highly intelligent, advanced 13-year-old with all of his faculty and function. He is a miracle. He is beautiful. I did not take any sort of legal action or recourse because I was just so grateful that he was alive and that I was well. But it was rough.
Yeah.
So rough to live through that experience. And then to have I had a second pregnancy. Another child was born 23 months later. That one went completely different because I wasn't in mommy mode. I was in risk manager mode. I owned the communication, right? I went in almost, very dominant, almost in a way that my new physician, because I did not let the same physician handle my second pregnancy and birth. But my new physician was almost off put because but I had to give her the backstory on why I had to be so in charge. And a lot of mothers are not prepared to be that way, do not advocate for themselves in that way. And but it changed the trajectory of my second birth. Um, and then I still faced some challenges afterwards because some of the postpartum care, like pelvic floor therapy, was
Mhm.
not part of the protocol 11 years ago.
11 years ago, even now, Princess, even now, you unpacked so much in there for me. I had listened to your TED Talk, which was absolutely wonderful. Breaking bad agreements. It almost sounded like, had you known about your OBGYN's pre-planned vacation, that would have been a bad agreement that you would have broken. There
Yeah.
was the communication. I mean, now looking back, that would have been a bad agreement that would
Yeah.
have been broken, right? And
Yeah.
and rightly so. Like there are just relationships, even at the very end, where they have to end to protect yourself. And
Yeah.
so, just in to bring it this full circle, I almost wonder in risk management, there is a significant need for communication. That's the
Yes.
fundamental takeaway I'm taking away from this conversation
Yeah.
on the mother's part, on the doctor's part, and when we're talking about maternal health, but just as organizations, communication is foundational to risk management, is it not?
It is. It is because, when you think about the traditional risk management process, it sounds like so much of it happens in a silo. Because if you just think about those big buckets of like, what is the risk management process? It is a series of identification and the tools and resources that you use to identify that comes into play. But you identify, you assess the risk, you analyze it for likelihood and severity, you introduce solutions, you craft solutions, and then you monitor them to establish control. That is 30,000 feet, the risk management process. But embedded in the identification, when you identify risks and concerns, you typically ask questions. Who are you asking the questions to? How are you asking the questions? How is the medical community relative to maternal health really assessing what their patients are experiencing and what they need? And especially when they're at that critical transition, like you said, of going home. Our entire system is monetized, and they want to flip those beds as quickly as possible. I've been in that situation of like, yep, you had that baby, you look like you're okay, time to go. And I was barely assessed. Went home after my first birth, went home with a whole host of issues. My incision from my C-section did not heal properly, and I had to have home care and wound care for 13 weeks. 13 weeks. Um,
Wow.
I ended up with, I'm telling you that it turned into a horror story. I ended up in the emergency room at one of my local hospitals, and I left that emergency room with MRSA.
I'm sorry,
And
you went to the emergency room after your C-section
yeah, yeah,
because of poor
a week
healing.
later because of poor healing. And some of that was, in full transparency, some of that was due to my own, um, I had a child who had some immediate needs. My child was having seizures and he had some challenges initially, as I alluded to. So I was under a lot of stress leaving the hospital. I had gotten great information about postpartum depression, and my husband at the time was given really good guidance and some support there. But in terms of my physical health, I was not given a lot of really great instruction, guidance, and the follow up after that was just, I mean, it was just mediocre at best. I can't even sugarcoat the experience. And me not knowing how much activity, what did limited mean? What did restricted mean? I still to this day, because mothers, we keep the baby file. I have that folder, that burgundy folder with the baby's name and the hospital's name. And so when I look through the massive amounts of paperwork that I was given, nothing really prepared me for what I physically needed to be doing to start to care for my body better. And as a result, I had a poorly healed wound. And
Within a week, princess,
yeah,
within a week of
within a
your
week, I was back
C-section,
in
you
the
were back
hospital.
in the emergency room.
Yes.
For me, this is important to know just from your experience, because what you said at the start of our conversation was active listening.
Yeah.
Active listening is not passive listening. Active listening is almost asking the right questions and waiting for that response.
Yeah.
And one of the things that we were teaching OBGYNs and OB nurses about our services were that we were asking questions fundamental as, what type of bed do you have at home? Not every mom had a hospital bed to help her get up and out. And so when we were having moms be readmitted back to the hospital, we had found that a lot of them were just struggling those first few days of getting out of their own bed because it didn't have the rail support. It didn't
Yeah.
go up and down. It was flat, and they had never practiced that in the hospital. Some of these moms, they were living in 2, 3 story walk-ups.
Yeah.
They did, and again, when you say restrictions, I'm like, that is so buried deep in the paperwork. If they're a single mom, they were carrying that baby up those stairs.
I want to give you this. And now this might sound like first world problems, but when I left the hospital with my first child, the vehicle I had at the time, I had a Cadillac CTS. It was a nice car, right? But that car, if anybody knows anything about cars, that car sits really low to the ground. And that was almost the worst car to be picked up in, because even though I could sit down in it, getting out from that position, it was really tough. It was the back seat, because I wanted to sit with the baby. The back seat was cut a little small. It was a little tighter. And again, I'm not putting all of this responsibility on the medical community, but that's when I talk about risk. This is the side of risk that I love. So many opportunities. There is opportunity to ask, what type of vehicle are you being picked up in? Are you a single mom, right? Do you have help? If you've had a C-section, you can't, that car seat situation is so heavy. And that little cute, my babies, Rebecca, you've met me in person. So you see that I am, 4'10". I am a petite woman. My first child was 8 pounds, 9 ounces. The second child was 9 pounds, 6 ounces. Um, it was a struggle. Those were some big babies. And I, like I said, probably contributed to, my own wound issues because of the size of my baby and not really being told how to properly hold the baby, or lots of things that were just missed in the process or just taken for granted. So there's so much opportunity and for active listening. And the other one is continuity of care, really coordinating my first baby was in the NICU. So coordinating between the NICU and postpartum care, and then going back into your primary care. I stayed in the same hospital system, but I swear it felt like I was in three different hospital systems, going from appointment to appointment because of the questions I was asked. I was like, is anybody reading the chart? I'm a new mom. I don't want to answer these questions over and over again. So this entire experience is just ripe with opportunity to increase in communication, increase continuity of care, and decrease, patient acuity. I mean, it's just so much.
So, if you were given the opportunity to consult with a large maternity hospital, and I mean, just for kind of our audience to know, maternity services are some of the most profitable in the country. They're the most well-funded. Over half of Medicaid is covering 50% of births that take place in this country. It's well-funded. It's government supported. There's so many grants out on it now. What I want to know is that if you were consulting with a hospital and you were going through these steps of mitigating risk in maternal health in a package, is this what you would cover? Active listening, continuity of care, and decreasing patient acuity. Is there anything else?
Yeah, you know what? I would actually frame this a bit more creatively and a bit more balanced for both sides. I would actually frame this, and you tell me what you think of it, as a burnout and decision fatigue discussion. Because we know that the medical community is overwhelmed, right? Sheer volume, right? The medical, and the profession itself is heavy and complex, full of technical issues and challenges, and we're trying to integrate staff and mitigate emergencies and integrate technologies and have all of this going. And the work that has to be performed comes with a lot of stress. And so we need to talk about burnout and decision fatigue on the part of the providers. And then now you're talking about new mothers. Again, first time or fifth time, doesn't matter. Every baby's different. Every body is different. And so now that mother is at risk of burnout, decision fatigue, chronic stress. So I would actually frame the discussion that way, with active listening being one of those practical solutions that we unpack, along with some other ideas. But yeah, I would actually frame this as a burnout and decision fatigue discussion, because that gives us an opportunity to look at both sides and to see how people are being impacted by communication and other issues.
You are so right. I want to kind of end with this, because we're nearing Black Maternal Health Week. We're in the National Minority Health Month that was instituted a year or two ago. And as we talk about a lot of Black maternal health issues, we're constantly saying, well, the United States is of the top developed nations in the world. We have the highest maternal mortality rate. What we also don't discuss is that our OBGYN to patient ratio is one of the worst of all high income nations. That means that we have less OBGYN and midwife or midwifery support for women giving birth than other countries that are equally in terms of high income. They have many more providers that offer those women. So they're seeing a lot less patients, right? Our OBGYNs are slammed. So what you're saying to me is just groundbreaking. You would frame the discussion, if you were to consult with a large maternity hospital or health system,
Sure.
right, about mitigating maternal health or mitigating risk in maternal health, you would frame the discussion as burnout and decision fatigue.
On both sides.
On both
Both
sides.
sides. Yes, definitely on both sides. And, the medical profession is so unique. When you think about I'm a global speaker. And even though I'm not branded, I'm not necessarily a motivational speaker. I do believe that motivation and inspiration are a byproduct of what I do, right? People are moved to action when I speak. And I think that when I think about what doctors are going through, every other industry gets cheerleaded. We tell people, you can make mistakes and you can bounce back, and we care about you. We say that about every other profession except the medical profession. It is one of the only ones where, no, we actually expect you to be at peak performance because our health and our lives are of concern, right? And so it's one of the only professions where there's no slack. And so there is an inherent unrealistic nature to the expectations. And so that means, because that's not going to change, right? It's not going to change. Nobody's going to accept a lesser standard from a medical professional. But it does mean that we have to approach it. We need to reframe how we come into this conversation. We have to be proactive about using things like progressive muscle relaxation. We have to be proactive about helping doctors and nurses and everybody along that entire, delivery channel understand their risk for chronic stress at a personal level, their triggers, and learn how to manage those things naturally. Learn how to negotiate and navigate conflict, because every time a doctor wants to take one course of action and a patient wants something else, that's a conflict. And I believe that conflict is inevitable in every single high value relationship. And I can't think of one, thinking about this discussion, there on March 1st and March 2nd, when my son was born, 2013, there was no higher value of a relationship than the one I had with my doctor in that moment. And so when we have to learn how to negotiate conflict together and talk to each other and respect and hear each other out, especially given the risk around Black maternal health. So that's a whole other topic. Don't get me there today.
Princess, I cannot thank you enough. And I do have to confess, I went through your whole progressive relaxation training that you had on YouTube. It is beautiful. First of all, I closed my eyes and I was just guided by your voice, because I'll be honest with you, I have had the people's experiences that they'll share with me via email, sometimes via messenger or social media. People will reach out to me because they are moved to share their birth experiences. Like, I was not given the support. No one assessed my physical function. I had a C-section wound that opened up and I was brought back to the emergency room, just like you shared today. It is very heavy to know that we're not providing these services because, quote unquote, there's no evidence for it. And so it's a very heavy field. And I'll testify to your progressive relaxation training. If hospitals, if physicians, if organizations, rehab therapists, organizations want to consult with you, Princess, what's the best way to get in contact with you?
The best way is through my website, www.princesscastleberry.com. You can also find me on LinkedIn. I think I am the only Princess Castleberry there. And I always jokingly say, if you find another one, report her because she's a fraud. So,
Princess, there is no other. I have looked. The only place I did not find you actually was on X, formerly known as Twitter.
yeah,
So I will be
reason.
looking for you on all platforms, but I will be sending this out on all platforms.
Thank you.
I'm so thankful.
Thank you so much. Yes, Princess Castleberry Speaks on Facebook, Instagram, and YouTube, I believe. So,
Excellent.
thank
Well,
you.
thank you so much for joining us, and we'll speak soon.